Welcome, everyone, to another evening with Butterfly. Our mission at Butterfly Network is to democratize healthcare across the globe, and we're excited about the progress we've made thus far. However, democratizing healthcare is more than just changing technology or care delivery models. It's also about changing the way we think. Sometimes it's obvious what those changes should be, and we might all agree upon them. But in other areas, it's not so obvious, and we need to open our eyes to areas that are neglected. Tonight, we address one of those topics. 156 years ago, a lanky, awkward gentleman took the stage in a quiet little town in Pennsylvania and passionately outlined a vision for our country, for humanity. He said, 7 years ago, our forefathers brought forth on this continent a new nation, conceived in liberty and dedicated to the proposition that all men are created equal. If he were given the chance today, he would remove the word men and simply say, all are created equal. That is the most quoted portion of Lincoln's memorable speech, but not, from my perspective, the most important. This is the line that I believe should resonate with all of us, and I'm confident does with our panel tonight. It is for us, the living, rather, to be dedicated to the unfinished work which they, who fought here, have thus far so nobly advanced. The unfinished work, dedicated to the unfinished work. Such profound and prophetic words. Ironically, 100 years later, a preacher stood in front of thousands of people, Black, white, Hispanic, Asians, and Native Americans, professing a dream and inspiring a nation to continue that unfinished work. His thundering voice should echo in our souls, and we should all share in that dream. But it's important to note, this is not just an American problem or a Black versus white problem. This is a humanity problem that dates back thousands of years. In 3500 BC, the Code of Hammurabi had language about slavery, and it was part of the culture. The pyramids were not built by union workers, and whether it's race, religion, gender, or sexual persuasion, humans have struggled throughout history treating those different from ourselves equally. We're just not that good at it, and we desperately need to be. Now, we often think this doesn't apply to the medical field. We take an oath dedicating ourselves to our patients, and regardless of who they are, we may think we do so equally, but sadly, we're humans too and suffer the same faults. There is unfinished work in medicine too, and we're going to address that tonight. Now, having said that, and before we do, it is important that we recognize that we've made progress, and even more importantly, we've demonstrated we have the capability to make this better. We just need to constantly address it and keep working at it. And as Lincoln so wisely stated, dedicate ourselves to the unfinished work. And so that journey continues tonight. We're fortunate to be joined by an amazing panel of leaders, passionate humanitarians, each remarkable in their own right and diverse in their interests and talents. Together, and candidly, we're going to tackle this challenging topic. We're not going to focus on who is to blame. We're going to shine a bright light on the problem and talk about what we can do to move the ball forward. Move the ball forward, something one of our panelists knows very well. Let's all take a deep breath, open our minds, and be instruments of positive change. So let's start now with introductions. Our panelists will each going to give a very brief intro of themselves so you can get to know them better. And then we're going to leverage their amazing talents. Dr. Zayden, can you go first, Amy?
Absolutely. Thanks so much for having me. I'm honored to be here. My name is Amy Zayden. I'm an emergency medicine physician at Emory in Atlanta. I work at Grady Memorial Hospital, which is a public hospital. And I co-direct the Georgia Human Rights Clinic, where we provide asylum evaluations for those seeking asylum. My work focuses on barriers to care for refugees, immigrants, and asylum seekers.
I'm Keith Ferdinand. I'm a clinical cardiologist in New Orleans, Louisiana. I'm from New Orleans. I'm a native of the Lower Ninth Ward. I practiced in the Ninth Ward for 30 years and had the Healthy Heart Community Prevention Project. We did a lot of community outreach. We pioneered, along with my friends out of Baltimore, the idea of going to barbershops, beauty shops, churches, sporting events. And presently, I'm the chair of the Association of Black Cardiologists Access Program to make sure that evidence-based medicine is available to all patients, regardless of race, ethnicity, sex, gender, socioeconomic status, or geography.
Welcome, Professor. And now my good friend, speaking of sporting events, Doug.
Well, I guess I'm the guy that moved the ball forward because
that's correct,
quite
sir.
naturally, I have no MD in my name. I'm not a medical professional at all, but I want to say, number one, I'm on this line because a few years ago, I met a guy by the name of Dr. John Martin, you all have heard, and the passion that he had for taking care of people from preventive medicine with the heart. And I became a part of it because I had a brother who had some heart problems, so I wanted to know. But the most important thing tonight, I want to thank you all for what you have done, what you're doing, and what you're going to do for the inequality in our minority community, because I think that is vital today, yesterday, and tomorrow. And it's important that you all discuss that, and that's the reason why I'm on the lines.
And so Doug is so humble, so he won't tell him. So I'll give his credentials. Doug Williams is the first Black quarterback to win the Super Bowl. He is an amazing humanitarian, and he's a senior executive with the Washington football franchise. Thanks for being with us, Doug. Ken.
So you go from the guy from moves the ball forward to a former college football player who fumbled the ball quite a bit. That seems like a good opening for me.
We were going to keep that a secret, Ken.
Yeah, there you go. Okay, Bazunin, that means hello, friends. My name is Ken Bernard. I'm a second-generation Indian Health Service physician. I'm an enrolled member of the Turtle Mountain Band of Anishinaabe, or Chippewa. I'm an emergency medicine physician practicing in the Four Corners area, founder of Pinnacle Emergency Medical Group, as well as the Native American Emergency Medicine Consortium. And I'm very honored to be here on this panel with all of you. I'm hoping to learn a lot. Thank you.
And Victoria.
Hi, thank you, John, for hosting this important discussion. I'm a Vietnamese refugee myself, and that inspired me to want to pursue a career where I could, contribute to the community and address mental health issues. Because when my family came to the United States, we had a number of family members that also had mental health problems. I'm a clinical psychologist and also an associate professor at the Community School of Public Health. I am I'm the director for the Center for Innovation in Mental Health, and also the Global Mental Health Director for our Center in Immigrant Refugees Global Health. Happy to be here. Thank you.
These are the things that we want to look at tonight, and they serve as a backdrop for this conversation. COVID itself has had an incredible impact on people differently across the country and across the world. We want to talk about the social determinants of health, some racial disparities in the physician workforce and what kind of impact it has. Something that I think was eye-opening for me and candidly embarrassing, and that's the explicit and implicit bias that exists in medicine, and what vehicles have changed, both these people are, as well as what we can do. And then feel free to use the Q&A section of the Zoom to ask questions. We'd love to share your ideas and questions and get you to be part of this conversation. So let's get started. I think one of the things to look at real quickly is we've seen this information on television about how COVID has affected different people differently. There's been an exorbitant amount of impact on different communities by race across this country and across the world. This is the chart that shows the deaths per 100,000 people by race, and certainly the Black community has had a huge impact. The Native American community has been hammered by this striking difference. If you look at this, this is the age-adjusted hospitalization rates by race. And again, I was struck by this, that the Native Americans are really just getting pummeled by COVID. And this was something I didn't even recognize at all, and certainly has not gotten a lot of media attention. So why don't we pause here and let the panel kind of give their input on why they think this is actually the case. And Ken, maybe we'll start with you and say, has this been what you've seen? And do you have any idea as to why it's been so different within the Native American communities?
Certainly. Let me step up forward and say, the data is only as good as the inputs that you receive. So let's be clear on, we are definitely underrepresented and undercounting the number of cases as well as the mortality amongst these ethnic minorities, in particular Native Americans. For example, federal facilities and Indian Health Service facilities aren't necessarily required to actually report this data publicly. So there's been estimates that maybe 40 to perhaps even 50% of the current facilities are not stating those numbers. So that makes me concerned that we're actually not getting the full picture here. It is certainly what I'm seeing in clinical practice. Again, in Arizona in particular, we are, and in New Mexico. And you're twice as likely to die from the disease if you're Native American. You're 3 times more likely to actually contract the disease if you're Native American, and you only make up a fraction of the population. So certainly we are seeing those disparities in both prevalence and mortality and hospitalization.
Yeah, well, where I'm from and where Doug is originally from in Louisiana, we saw these disparities early. We certainly recognize that race is a social idea. It's not really science. It's not genetic based, but it has a lot to do with how people live, the pressures they're under. For instance, we say socially distant, stay away. But if you have a multi-generational home, you're what they now call an essential worker, to give it a nice name. But you're working at a job, minimum wage and all you can steal, but you got to go to work. You can't work from home. You don't even have a laptop at home. You're going to be more exposed. You're using public transportation to go to and from work. And then you don't even have insurance, or if you have insurance, you don't have an identifiable primary care source. So when you go to the doctor when you're sick, and that's when you see the emergency room department uses the primary source of care. In Louisiana, we call that a gumbo. It's a mixture of things that goes together, and that causes these disparities.
The fundamental problems in our system itself actually lead to, and COVID basically just put gasoline on the fire and accentuated everything, is essentially what you're saying, Professor.
Correct.
We have certainly seen that in New York City. Community School of Public Health conducted a 12-week survey of New Yorkers, 1,000 New Yorkers each week, from March to May, and we had about 40% reporting job loss, 40% reporting food insecurity, 16% reporting social isolation, and then certainly high rates, 35 to 40% depression and anxiety risk. And all of this is much higher in Black and brown communities. Very similar to the findings that you showed earlier.
I just want to add to what we sort of emphasized, but it's interesting to me that much of the data is not reported by language either. And most of our information about coronavirus is in English. Most of our testing sites are in English. Most of our hotlines are in English. And so you can imagine if you don't speak English, that adds another barrier to what information you're receiving, as well as if you're getting testing. Many of our testing sites are located in places that are geographically very challenging to access. So there's a lot of different things to think about if your primary language isn't English.
I think you bring up actually the great topic, and maybe it leads right into the next slide, which is what are those actual social determinants of health? What all of you, and I guess I preamble this with, I think COVID brought up something that I think that we should mention first. And I jumped the gun a little bit because I'm so moved by what all of you have said. But this is not a new problem. COVID is not the first disease that's come down the road that it brings out some differences in how diseases itself have affected populations differently. And I wonder, I throw this up here, if any of you want to comment on these statistics or maybe some others that are there. I know they're striking in different populations, but I put this up there just as a springboard for conversation.
Yeah, John, I think I can jump in here. You're looking at a wide range of conditions. Here you're talking about Black women and some of the diseases that are disparate. And it's not just COVID. Here you're talking about pregnancy, heart failure after pregnancy, low birth weight, children dying after pregnancy, certain types of cancers. But let's go to heart disease itself. The heart disease risk in Black women is so high that their death rates are similar to white men, more similar to white men than they are to white women. And it's driven again by that same wide range of risk factors that we described in COVID. What I call that is a sentinel event. A sentinel event means something when the Joint Commission comes to look at your hospital that's so bad that they almost want to shut the joint down. For instance, you have people who have devices that get infected. They have sponges left in the belly after surgery. They fall out of the bed and break their hips. Those are sentinel events. This whole COVID-19 mortality difference is a sentinel event for the healthcare landscape of the United States. It's a marker that something really bad is going on.
How do you think what do you think is the best way, all of you? And Doug, you have an amazing platform. You played an incredible role in history. How do we leverage the position that each of us have to bring this up to the attention? And there's a hospital in Houston, and unfortunately they couldn't be with us today, where they challenged themselves to look at the mortality rates of maternal fetal mortality within their institution. And they found a dramatic difference between the two, and they addressed it. So how do we bring this to light? Doug, do you have any ideas on how we might do this? How do we bring this to the attention? And what has your experience been?
You know, and like Dr. Ferdinand, I am from Louisiana. He's from New Orleans. I'm from Zachary, but I'm more of a rural area kind of. That's where I grew up. And I'm just sitting here thinking and just listening. There's an area that I live, it's about 20 minutes from me, and I can, guys I went to school with and ladies that I went to school with, that I know that do not get an opportunity to go to the doctors, even when they're pregnant and everything else. And you just wonder why. Because I think the disparity is because of where they live. And I guess another one is from an economic standpoint, of being able to get to where they need to get that health care. And that's why it's important that, you know, we all is on here today, because to me, it breaks my heart just to sit here and think about it, because I know so many people. And just, we was talking about COVID-19, I'm sitting here in one area down little gravel road where there's about 10 people that live down that gravel road that I know. 2 of them have died, and 5 of them are in the hospital now with COVID-19. And it's all right there because they didn't take the time out to go get the test. They don't know where to go get the test. And I think that's the most important thing that is hampering a lot of the sickness and the things that is happening in the rural areas.
This is the kind of stuff that shakes you at your core if you're in medicine. So let's pull up the slide about the social determinants of health. And Doug expresses this so well, and this is endemic within our society. And what I love about this panel is we actually stretch the breadth of who are vulnerable within our society. And each of these issues are important. And I wonder if each of you might think about how you might bring to the surface, if you will, for our audience to actually address this issue.
Well,
I think I could talk about it. I mean, what you initially brought up is about these issues are historic, traumatic, and they're tragic, and they're certainly endemic and part of our culture. They're effectively the way that we have determined what we, or more important, who we decide is of worth and of value. When we're talking about the unequal distribution of power, privilege, and respect within our community. Those prior conditions that we talked about are many of them are chronic, meaning you're not going to see them until the 5th, 6th, 7th, 8th decades of life. So therefore, I think it's difficult for most people to conceptualize those disparities. However, something like COVID, something when it came in a matter of months and was so proximate, and we could see the change and how drastic it was, opening up those fissures and the difficulties in the infrastructure of our healthcare system and our public health system really brought a light to it. John, I think you said yesterday when we were talking about it, what was important is these are difficult conversations. Let's just be brave and have the courage to actually discuss it. 1, what led up to it. 2, what are the barriers and how we all may play a part, even myself trying to fight it, but also contributing to it. And 3, what are going to be the creative solutions that we can bring forward that are also going to be difficult decisions and compromises that we may need to make.
Ken makes a very important point. He's pointing out that there's structural problems in how we treat people and how we see people. If you look at those individuals who don't have insurance and use the emergency room as the primary source of care, when you see them in heart failure, you see them with end-stage renal disease, they need dialysis, you see them with a stroke, and you know that the risk factors that led to that have been going on how long? 2 years, 3 years, 4 years, 10 years. So just putting a Band-Aid on them, and I know emergency room docs work really hard, but sometimes you must get frustrated because you say there's something wrong how we're doing this.
All the time.
I think we speak to prevention also. There's so much work that we need to do way earlier, in terms of educating people about habits and health behaviors, mental health, and the intersection of social determinants, mental health, and health. Which is what we're seeing now, and systems need to work together. That's another problem we have, is our systems don't work together, and they're especially broken in low-income communities. There's a lot of work to be done there.
So Victoria, you bring up the issue of mental health, and I want to pause for a moment because my family has been heavy into this, and my brother is in the mental health, and I'm sure he's listening. And always gives me grief because he thinks I underestimate the importance of it. And I try not to, but we don't know it well. I think it's really important, particularly now more than almost ever.
Yeah.
I mean, and I don't want to minimize it because it's probably not even fair to say it, but I'm going crazy being stuck inside my house. And so I can't even imagine what it's like for others that are in this situation who truly have real needs. How have you seen the impact of COVID, and how has it impacted minorities? And I think I challenge all of us to actually raise the level of awareness around mental illness and the mental stresses.
Yeah, absolutely. We're seeing extremely high rates, more than 2 to 3 times the rate that they normally are, right? 35 to 40% are at risk for depression or anxiety or even trauma. And these results are consistent. We're seeing it consistently across the 12 weeks that we've surveyed. We've seen it in another KDY, which is the school system that we work in. We're surveying students and we're getting similar rates. The CDC has found similar rates across the United States. These rates are extremely high, and it makes a lot of sense if, we're all experiencing this collective trauma together. And the outlet and the strategies we usually would, use to manage and respond to a crisis like this is to be together, to reach out to your community. And that is harder to do now more than ever because we don't have, we can't interact physically because of social distancing orders, and so people are more reliant on technology. And with technology, we have a disparity. We've got varying levels of access to technology, which is the medium we need to socially connect. So, again, the social determinants play themselves out there as well. So I think, we've basically got 3 pandemics going on. We have COVID-19, we've got mental health, and then we've got institutionalized racism and disparity, which is all widening disparities.
I know we're going to lose Doug at 5:30, and so I just want to ask a question. You bring up the concept of institutional racism, and Doug, throughout your career, I know you have to leave at 5:30. I want to give you the chance, just at least for the audience, to share what your experience was like, because it's very unique. And for those that don't know, there are many beyond here that are young. Doug was the quarterback that led the Washington franchise to the Super Bowl victory, but he did so in an era when it was widely believed that a black man could not lead a team. And I don't know, Doug, it might be just worth sharing with everyone what that experience was like for you to crack that barrier, what impact it's had on you, and how that might be an example for all of us to actually step up here and try to make a difference within society itself. Because you lived a very prominent part in sports, probably the biggest sport ever and the biggest role.
Thanks, Doc. And sitting on this webinar today, I'm thinking about what I had to go through as a player back in the late 70s, being one of the first black quarterbacks to get an opportunity to play in the league. And I compare it to today, inequality of healthcare to so many people that I know. And I think for me, the reason why I'm on here, Doc, we started out, it was there to care, it's about heart. And I know we don't get that preventive medicine or opportunity to catch things before it's too late. And I think that's where we are today. The inequality is basically the same thing. And I look at that as people getting treated, our people, minority people are getting treated like myself as a quarterback. But I don't compare it because I was helped enough to do that. I'm talking about people who are afraid to go to the doctor, number one, because they're afraid something might be wrong. And another part of it is just not in reach for them to go. Nobody is pushing them, and nobody's offering them an opportunity to go and get that health care. So it's something not only all the people that are on here, all the medical professionals on here, I applaud you for being on here and wanting to do something about it. But I think we're at that point now. It's not about wanting to do something about it. We got to find a way to get something done. We know we're not going to hit everybody, but we can get the masses. I think if we start doing that, and this is a great start. And like I said, again, I appreciate everybody on here, and I appreciate me being a part of it without any kind of medical degree, but my heart is in it. And Dr. Martin know whatever that I can do from a passionate standpoint, I'm here. And anybody else, and Dr. Ferdinand, when I come to Louisiana, I'd like to get a chance to sit down and talk to you.
All right.
So I appreciate you.
Can I thank Doug for his lived experience, because I think that's what many of us as physicians don't necessarily experience, myself included. And without that, we wouldn't have a way forward. I'd also, if I can, introduce my friend Haval Kelly, who's a cardiologist who has had the lived experience as a former refugee. And I was hoping I could bring in him to this conversation as well.
There you go. Welcome.
Hey,
Welcome.
Doc.
Welcome.
It's all right to lead, Doc, but enjoy. Thank you.
Good luck on the season, Doug. We'll be watching.
All right, thanks.
All right.
I think for all of you, as Doug leaves, I just want to share just a moment. He's a very special human who really desperately cares about what we're doing. And Dr. Ferdinand, I certainly encourage you, take him up on that. It's a genuine offer. He's a very special human who could make a difference in Louisiana, I know. I've had the pleasure of being in airports with Doug, and it's amazing the kind of attention that he draws. So please, he would love to leverage his position to help. I know that for a fact. So Haval, welcome. You're a hero for many of us. Please introduce yourself. I'm so thrilled that you've joined this webinar and you have so much to share with us. So please tell your story, if you don't mind.
Oh, thank you so much. I was hoping you'd talk at my wedding like this, call me a hero, so my wife couldn't change her mind. It's an honor to be here, Dr. Ferdinand. I've been reading all of your work. I'm trained by Dr. Lawrence Sperling, so I've been very familiar with all your publications and all your work. So I'm honored to be on the same panel with you. And thank you, Amy, and everyone here. I think one other thing that my experience as being a refugee living, in Syria and in Germany and coming to the US after 9/11, I noticed something very important. Like, we live in a small city called Clarkston. I don't know if you're familiar with that small city in Georgia. It's actually the most diverse place per capita in the world almost now, almost like 60 languages spoken. But one interesting part of Clarkston is half of Clarkston is African-American and the other half are refugee. And you start noticing that after the language barrier is overcome by a lot of the refugees, they start facing the same issue with like lack of good education and healthcare, as same as like the minority group who are living there. So that's one thing actually that drove me into medicine, because early on I was like, my neighborhood, the only reason the ambulance came because someone got, either shot or stabbed or they had a heart attack. So that was something that I noticed, was like, I need to do something about it. And my brother went into trauma surgery. I was a terrible surgeon with skill set, so I became a cardiologist. And that something drove us because of our experience. And we noticed that there's an interaction between socioeconomic status and also, minority group and immigrants and refugees dealing with healthcare issues. And it goes down to the same issue that people are talking about, education. Early in COVID-19 in March, there was no material translated in any of the languages to tell refugees and immigrants how to get tested. So you have people like running around in neighborhoods not knowing even that COVID exists. So that was very sad. And then, the local church in Clarkston did a 200 drive-through testing and figure out where the hotspots were. And there were only 2 apartments that had all the infectious rate. But if they didn't do that, it would have been the entire city almost like affected by this. So I'm just bringing the issues is it really comes down to simple thing like education and prevention that does make a huge difference in these communities, especially in our community that we notice in Clarkston.
John, one of the things, and Havel, you may like this, in Louisiana, we took the step that originally you had to have a car and go to a suburban mall to do the drive-by testing, but a lot of people don't have cars, they can't get out there. So we now say you can come anywhere, we can set up a shop and do the testing. The other thing is a lot of people who are recent immigrants may be, quote, undocumented, which I don't know what that means, but they don't have the papers. So they don't get tested, but they get sick. So we removed that barrier in Louisiana. Our governor was smart enough to say, if you don't have a driver's license, just give us your name and your number and get tested.
I think you bring out such an important point, both of you, and that is we think we're doing good with what we're doing. We're setting up testing, you can come in here, and we're just not thinking through the impact for the broader community and what's there. And I think people are well-intentioned, but don't have the knowledge and experience that all of you do to understand that by the very nature of what they're doing, they're excluding people out there and magnifying the problem.
I think that's a good point. And one area where we've seen this is with telehealth, as many of the offices have closed, especially the clinics that many of our patients rely on. The move towards telehealth has worked for some, but not for many. So many of our individuals in Clarkston don't have the appropriate phone or computer systems that they would need and don't have internet. So it adds sort of another level of barrier of how you get that information, and an easily overcomable barrier if you can democratize internet.
Yeah, I do virtual visits all the time, Amy, and I agree. Non-English speaking, English as a second language, older persons, some people still have flip phones, don't have any internet access. And the telephone visit is okay. They're reimbursing it right now during the pandemic, but it really is not the same as the real virtual visit with the laptop or the smartphone.
So I throw this up here, and I was struck by some from data from this, and that is the race of the physician and the race of the patient needs to match. And I was struck by this because, and again, you know, I apologize to all out there for my ignorance. I didn't think it mattered. I mean, I really felt like I cared for everybody equally. But when you start looking at the data about what difference it makes, whether we see someone who actually is like us, and whether it's a physician that's of the same race, of the same beliefs, of all those things, it makes such a huge difference. And if you look at this, this is a really important problem because we don't match. I mean, the number of physicians that are out there don't match the number of patients that we see. So there's a mismatch from the very beginning just by the nature of who actually is in and practicing medicine. And okay, we might minimize the fact that that makes a difference, but if you look at this next slide, you'll see actually the amount of impact that actually it makes. And in this next slide, all the things that actually can happen if the race, this is striking. I mean, I would challenge most physicians to say, do they really know this? That if the doctor and the patient have the same race, it increases the time, medication adherence, shared decision-making, wait time. Can you believe this? Wait times, cholesterol screening, understanding of cancer, and the patient perception of treatment options. Would you actually believe that this changes based on the fact that whether or not your patient is the same race as you? I mean, I would ask the panel, did you really know this? And if so, have you actually seen a difference made in the individual patients that you treat?
At the Association of Black Cardiologists, you don't have to be Black. You don't even have to be a cardiologist. We really want people who are dedicated to treating people fairly, regardless of their race or background. And we know that there are not enough, for instance, you talked about African-American, Hispanic, Asian, immigrant. There are not enough of those various forms of a provider to have enough to take care of their population. So we will need sensitive physicians. I don't care if they're from Boston and they're working in Clarkson, they got to do it right. So that's one thing. The second thing is we need a pipeline problem. Pipeline is what comes before you become an MD. It's before you go to college. We need to help educate these kids and make them believe everybody's not going to be Doug Williams. I mean, somebody needs to really understand the value of education. I'm from the neighborhood. I'm a neighborhood kid. And I remember they put all of their emphasis on me doing something great going forward. And we need to nurture other kids like that.
I would add to that there are differences in outcomes based on gender of your physician as well. And so that's something that both gender and race are important. If the statistic that you showed before with Black women, that's the same. We need more Black women in medicine. And we've seen those outcomes with MIs in the emergency department. So the gender of your physician actually can impact the outcome of whether your MI is detected and the outcomes thereafter.
And this problem is even more pronounced in mental health. There are even fewer minorities in mental health. And many minority communities come from cultures that have low mental health awareness or literacy, and as a result, there's a lot more stigma against mental health, and so it's much harder to get more in the pipeline earlier on because it's discouraged. And I remember when I told my parents that I wanted to get a PhD in clinical psych, they were like, well, why don't you become a real doctor? Like, why would you waste your time doing this? And for me, I don't think that I ever thought about being a professor or a clinical psychologist until I met somebody who was that. And that was what opened the door for me. Because before Dr. Stanley Sue, who was one of my mentors, I thought I was, if anything, go to med school or be a teacher, which would have been fine. But, I just didn't even think about this other alternatives. I think in many ways, representation is really important in all aspects.
Let me ask.
And I would, sorry, just to break in, I would say that this problem breaks into gender expression and orientation. So all of our brothers and sisters from the LGBTQ plus and two-spirit community, as we call them, where I'm from, also underrepresented, and also their issues within healthcare, a marginalized population. And furthermore, I think it just comes down to mentorship. I mean, get it, like physicians, all healthcare workers, allied health professionals, get into your schools, start talking to your kids. I'm a part of a couple of organizations that try to do that. The American Indian Society of Scientists and Engineers, so ACES, as well as the Native American Center for Health Professions out of UW, Wisconsin. And our goal is exactly that. Get minority students, mostly Native Americans, interested in STEM and healthcare professions and support them as best we can.
Yeah, before we go on, I have to say something. Again, I have to call out Haval because he started a program a few years ago called YPI to do exactly this. And I was hoping you could just give us, Haval, a few of your outcomes.
Dr. Ferdinand, you brought a great point. I mean, like we could all day long volunteer and work in a small community, but unless we create leaders from those communities, the difference is going to be just temporary. And we noticed that working, because I volunteer at Grace Village Clinic, is a clinic, that does free care for patients, and actually they use the butterfly there too. We noticed that we could treat hypertension, diabetes, but the people who volunteer in the clinic might not reflecting some of the patient we have. So we started these collaboration. We started the Young Physician Initiative after I spoke at my high school 15 years later, and all the kids start emailing me and telling me like, I want to be a doctor because I heard you speak. A lot of kids didn't look like me. So what it goes back to, if you're just present in the community, and now we could do it much easier through the virtual space, I think you might inspire leaders in those communities because you're gonna go back to the community you lived and came from, most likely. And what you also could do is you could help other non-minority groups and higher socioeconomic status to invest in your ideas in those communities. I think diversity not only helps the patient, but also guides the other people to be more excellent in diversity and be effective.
I think this is so important. I'm digging inside to say, how do we get more people to inspire folks to be like you guys? I mean, this is an amazing panel of people here who have committed to different groups and have dedicated their lives to do it. How do we change the behavior of physicians to be part of a movement that you create? Dr. Haval, use you as an example. How many refugees like yourself are physicians in this country? What a handful. I could probably stick my hand in an auger and come out with the same number of physicians that are like you. How do we get that to grow? And Amy, you deal with an amazing population of people. How do we inspire them? How do we get them the right support? And I know for a fact that in the Native American community, I don't know how many Native American physicians are out there that are like you, that actually do that. I mean, I don't know, where's those answers come from? How do we inspire the group of people to do this?
Lessen the barriers, make it affordable, and promote people. We still look at many of our leadership structures that haven't changed. I think Haval should be a professor. I think he should be our dean. I think he'll hopefully be there one day, but we need to minimize the barriers for him to get there.
Absolutely.
And Dr. Ferdinand, can you comment on the new statistic that came out showing that Black men in medicine is much lower than compared to 30 years ago? My point is, how did we not see this coming? I mean, for the last 30 years. Can you comment, because you definitely must have more wisdom and more experience in that field. So.
I don't know if I have more wisdom, I'm older. Well, no, if you look at the statistics, there are actually less Black medical students now than there were in 1975, 1980. So it's been going backwards. What I try to do when I talk to big meetings with my white colleagues, I'll say, if you don't want to do this because it's socially the right thing to do and ethically the right thing to do, we need to try to save money. When you look at that 35% of people who are Black who are on dialysis, Medicare calls them disabled and pays $90,000 to $130,000 per year. That's 3 times the population of the percentage. If you look at the hospital admissions, and Ken, you probably see this, Amy, you probably see this, they come back for heart failure because they can't afford the medicines. They weren't given the appropriate instructions, didn't have follow-up. So now you have a $30,000, $40,000, $50,000 heart failure readmission that could have been stopped. If you have stroke, that's the #1 cause of permanent disability. It's driven primarily by uncontrolled hypertension and atrial fibrillation without anticoagulation. So what I tell my white colleagues, look, if we don't address these things, we're going to keep wasting money in healthcare, doing devices and medicines and hospitalizations, things that are preventable. We could put that money back into the communities in terms of education and prevention.
And I wish these words would echo in the halls of Congress, in the White House, across the country, because I think they're so on point and to what we need to do. You know, it's interesting. You probably know, I was a medical student, and Clyde Yancey was you probably know Clyde very, very well.
He's from Louisiana too.
Yes, one of the most influential people in my medical career, and the fact that there are fewer Clyde Yanceys actually appearing in the scene, to me, is just a devastating, actually, fact. And I think we need to change. We need to change the way we think. We need to change the way we inspire kids to do different things, and we need to lower those barriers. I think that's an important thing. I think there is overwhelming evidence. This, for me, is the most disheartening of all. And that is, okay, there are a lot of social determinants of care that make people, whether it's of color, of race, of religion, of gender, who have a disadvantage. But you would at least think that when you walk through our doors, we treat you equally. But the fact of the matter is we don't. And I throw 4 things up here as an example. There's no question the incidence of that your survival rates with a heart attack are different. Your chances of getting an intervention are different. Your chances of getting colon cancer treatment or pain medicine for your pain, or even being introduced to hospice, is different. And that, to me, is just incredible. It's just incredible. That's a fact. Nobody can debate this. This is an absolute fact. And it fundamentally gets to this. And that is, we all share this implicit bias against people that are different than us. So my question out for all of you is, you guys are aware of this more than anyone else. Have you seen this in medical practice? Have you witnessed this implicit bias that's out there? And how ubiquitous do you think physicians are aware that this is actually what happens?
There's actually good data to support this. There were some landmark papers that showed physicians have a pro-white bias, meaning when a number of physicians took the implicit association test, their results indicated they have a pro-white bias. So I think 100%. I think I've struggled with this because I used to think about this a lot, but I think that we may want to reframe how we think about it and move from implicit bias to systemic racism. Because I think without calling it out within the walls of medicine, we may be missing the point a bit.
Amy's pretty tough. I do think
It's tough.
I do think we have to recognize that just because we're educated and go to medical school, that doesn't mean we're not going to drag with us the 25 years of environment that we were exposed to. And in those environments on television, if you were from Mars or from Saturn and you looked at television, you would think that Black people love to drink beer and eat fried chicken because that's who they're marketing to. And you hear that these people are less than human, that they're criminals, that they're welfare mothers. So now you become a physician. You have that badge of honor, you have that education. When that patient comes there, you probably pay a little bit less attention to their symptoms. You know they have pain, but you don't want to give them any pain medicine because they are drug abusers. And it's so bad, John, that one of the slides that you're going to have to change, you're going to have to put kids up there. There are now outcomes with pediatric surgery, the outcomes are worse with Blacks. You would think maybe a kid, let's treat all the kids the same, but it's not so.
Yeah, I have to say, even I've engaged this personally. I mean, you guys can see my face, and I think one of the things that people say when they first meet me, they're like, you don't look like you're Native. Well, you know, I'm equal parts German, French, and Scottish as well. And what is expressed there is not exactly what I identify with culturally or ethnically. With regards to, you know, real clinical examples of how it plays out on the res, I mean, you can have physicians that haven't practiced in this community before. They know that we have a high amount of substance abuse, including alcoholism. You have somebody that comes in with altered mental status, which just means they're not acting right. Immediate assumption is they're drunk, right? Sit them in a chair and then we'll get back to them. And then you come 12 hours later or come onto a shift and you find that this person had a stroke and they're outside a window for treatment and they're going to be institutionalized or in a long-term care facility for the rest of their lives. Those are real stories and they happen all the time. I love what Amy is saying is, you know, for example, if you pick up a history book when you're in elementary school and you hear no stories about, you know, Native American leaders or African American leaders or refugee leaders, it's going to be a real tough. You have a real tough time trying to conceptualize the world where somebody who looks like you or identifies as you is actually making a positive difference in this world.
And I think this translates into science as well. Early on before going to grad school, one of my advisors said, don't do minority mental health. If you do minority mental health research and get into that path, you're going to get pigeonholed, and that's all you're going to be able to do. Go mainstream, because you'll be able to publish more and get recognized, and then go back to the minority community. And so if that's a strategy that's being taught, like there's an implicit bias there, or institutionalized racism, actually, that's that is lesser. That science is lesser than mainstream science. So I think we have to look at it at so many different levels, and it's everywhere around us.
So I want to say something incredibly challenging to all of you, and that is, I get what you're saying, and it's real. I totally get it, and I believe it. I recall viscerally when someone says I have implicit racism in me. Yet I know probably but from statistically, the data is clear that maybe I treated people differently. How do I distinguish between the visceral response of someone calling me a racist with recognizing that maybe unconsciously I treated people differently? How, Amy, for instance, in your words, do I actually rectify the two of us? Because I think the vast majority of physicians don't consciously think of themselves that way. And that's part of the problem.
I think I have to acknowledge it. I grew up in a small town in Minnesota where everyone looked like me, and I left, and it's a great town and the people are great, but it took me a lot of time. And I really have to credit my husband. It took me a lot of time to understand that I may have implicit biases and I may treat people differently as a result. But also it took me listening to my friends, to people who were different than me, and working in places that were sort of unfamiliar to me.
Yeah, you look at people, our diversity is our strength. And if you really look at it from an economic point of view, if we would embrace our diversity, the immigrant population adds so much in terms of talent and flavor and labor and sweat to our economy. It just doesn't make sense to allow different people to have different lives and different lifespan. We're shooting ourselves in the foot. I try to treat everybody the same, regardless of race, ethnicity, social class, sex, or gender. If a clinician is not doing that, he or she is then actually harming our society. It's not that they're not doing good for that person, they're doing bad for the society.
So how do we flip it from, this is inherent in who I am, because it's the nature of, I like the people that are the same as me, and that I can be better at this without being a bad person? I mean, that may be an interesting question, because racism implies that I'm a bad person.
No.
But I want to change the dialogue. I want to change the dialogue to, this is real. I identify better with people that are the same as me. I want to treat people the same, but there's an inherentness in my behavior that's different. How do we fix that?
Let me make one comment, and then I'm going to shut it down. I think we're talking about changing the structures, how people are treated where you live, change the educational structure, the food deserts, which the people at Emory have written a lot about, making sure that the public sources of care are just as good as the private source of care, that there's not a St. Joe's versus a Grady. In one place you get a different type of care versus another. So it's the structure. I'm really not talking about how you feel, whether you call people a bad name, whether you send a bad tweet, your Facebook post ain't right. I don't care. I'm talking about changing the structures of our society. And one last comment, Ken, I've been to some of the native nations. I joined with the Navajo Nation here in Louisiana. We're trying to reach out. I've been to a Pima reservation in Arizona, and they have dialysis units. They got things for end of care, but they don't have preventive stuff. So that's what we really need to do.
One of the important comment to talk about when it comes relation to race is not only an issue also that is common in, in certain community. Also, you see that among immigrant communities too. There's all this division. But I think one thing important that people need to understand, the Civil Rights Act was the foundation for the Immigration Act of 1965 for immigrants to come here regardless of any racial or color differences.
Thank you.
So if we recognize that, actually, we know what the contribution was from the African-American community brought up to why immigrants are here in this country, that could change the conversation about racism too. Then you become an ally instead of just saying, oh, I'm just a bystander watching what's going on in this country. And I think that's an important aspect that we always forget, the contribution of all the minority groups to this country. But also remembering a lot of the refugee resettlement agency are sponsored by Christian churches and HIAS, which is a Jewish foundation. So a lot of the Muslim immigrants who came from Syria were funded by Christian and Jews to come to this country. So all of these things have to be mentioned to bring up to this issue that we also more connected than we think we are.
John, since we're on a big platform, can I point out what Kelly's saying? Because I think most Americans are unaware of that.
Absolutely.
When you look at the recent immigrants, many of them try to distance themselves from other minorities, whether it be Native Americans, Mexican Americans, African Americans, because they don't want to be that poor, disadvantaged population. So they run as quickly as they can to the so-called majority population. What Kelly is talking about is the reason we have a more diverse immigrant population is because John Lewis got his head cracked in 1965. When you had the Civil Rights Act and the Voting Rights Act, it changed the Immigration Act, and that's what allowed to have a more diverse population. Before that, you had to be of European descent, and they had only a small percentage outside of that European population who were allowed to immigrate. Somehow that's missed. The immigrants get this idea, well, I don't want to be like these other poor people in America who are downtrodden, so I'm going to run away from them, and I'm going to scrub myself up and look, fresh as a Brady Bunch, and I'm not going to allow myself to be a minority. But the only reason you hear is because somebody was beaten and dragged and went through pain so that we could have a more diverse society. Thank you, Kelly.
We stand on the shoulders of those in front of us. There is no question about it. And it's why I'm such a proponent of history. If you understand history and what it took to get here, you have a better appreciation of what it will take to get there. But I think that there's some fundamental facts that are clear. And we're going to get to all the questions on the chat here in a second. But what can we do? We can own the fact that the problem exists. Let's all acknowledge it. It's real. This isn't just, some people, it's all of us that have to it. And all of us may have some implicit bias. I think one of the questions in the chat things, which I would love for you guys to answer is, do you feel in your own selves, do you have an implicit bias that you've recognized in yourself? And how do you protect yourself from having the same issues that are clearly out there in medicine? We need to prioritize the measurement of health disparities within institutions. We talk about readmission rates or mortality rates within institution, but we don't divide them by the different groups that could bring out these differences. We need to make racial equality a strategic priority. We need to make it first and foremost about what we do, treat everybody equally, and we need to build community partnerships because these social determinants of health are critical. So we have to get into the community. But let's flip it out to the group. I'll start with kind of the first question, and that is, do you feel like you have any of your own implicit biases, and what do you do to protect yourself against that? I would love to hear each of you actually say that because you're passionate about what you do.
Well, I'll speak up. May have them, I don't know. I'm from the segregated South. I'm old enough that I didn't go to school with whites. So I learned my educational background was only in the Black environment, but I tried really hard to treat everybody regardless of race, ethnicity, social class, sex, gender, or geography. And it's kind of funny because I'm a big time professor. Somebody from administration will come down from Tulane and they'll pull me out of the room. They'll say, Dr. Ferdinand, we have a VIP. Can you see them today? And I'll nod and smile. They don't know, you just treat everybody like a VIP. But I'm not going to correct them because I don't have time to try to get their bias cleaned up. But I think we as clinicians just treat everybody the same. I did have some experience. I used to be a professor at Emory post-Katrina, and Nanette Winger's office is in the middle of Grady. Even though she's this world-renowned physician, a cardiologist, writes, speaks all over the world, she treats people at Grady.
I don't have a great answer, I'll be honest, but I think for me, it requires a lot of reading, a lot of time, and a lot of reflection to understand to understand if I am treating people differently. So I used to leave shifts and wonder and think to myself, did I judge that person? Did I treat them differently? And the answer is usually yes, I'll be honest. So I think it takes a lot of reflection before encountering somebody, after encountering somebody, to think about how I could be better each time. I don't think it's easy. I don't think it's inherent in our medical system, in our medical education structure to teach that. I think as clinicians, we're used to wanting to be right and not be wrong. And so I think it's also changing the narrative of you may be wrong, you still have a lot to learn. So I would say
a lot of doctors aren't honest. You said you're honest with yourself.
I try.
Yeah, there's an incredible amount of self-awareness and emotional intelligence that's being exhibited through the screen here that is incredibly refreshing, and I think should serve as an example to all of us, because I think the mere fact that you ask yourself this question distinguishes you from the majority of us. And if there's anything we walk away from, we tell everybody, you should do this. You should do this.
It helps when I'm surrounded by people like Haval.
I think I paid her for saying all these nice things. So
As long as your wife listening, we want to make sure that she hears all this. We want you in a good standing after all of this.
Even more amazing.
I just finished fellowship. She's been attending cardiology for 2 years, so she's definitely the smarter certified on paper. So.
Cardiologists are interesting folks. I was the president, you guys should know, of the largest cardiology group in Washington. So I always love to tease people and say, I don't know cardiology, but I speak it. It's an interesting group of people that make huge contributions to the world. There's some questions that exist here in the chat room. And I said, do you think making COVID-19 testing sites and drive-thrus has added to the disparities?
Yeah, I made that point. I said that you needed to have them in public available sources where you have public transportation, walk-in, where somebody can just walk in, and remove the shows your driver's license and your insurance, because it becomes a barrier for the so-called undocumented immigrants who are not going to go somewhere, and even if they have papers, they just don't trust the government. So just take that barrier off, because people are going to get sick. They're going to seek care. So you may as well get the diagnosis early so you can contact, trace, and isolate. That's what we're trying to do in Louisiana. We really are working on that. We have a health equity group that meets and talks about these issues.
How do we get that to the national dialogue? I've never heard this mentioned once in a national briefing. Not
really?
One.
We had a discussion about that this morning. I think our politics needs to change, and not just electoral politics, but how we look at people. I really believe that America is a great country, and it will be greater when we start to value everyone. So when we do something like we're going to have universal testing, then you have to make sure that you set up the pathways to make that happen. And if you're going to do that, you can't just say you got to drive out to the J.C. Penney's and the suburban mall in order to get tested. That just doesn't make sense. You're going to miss so many people. The hard reality is I'm a child of New Orleans. In 2005, 1,500 people died from Hurricane Katrina. And the people who drowned, the people you saw on television, the bodies floating, the people by the convention center, were that 40% mainly Black poor people didn't have a car. They couldn't get away. They couldn't get out of the storm. So I know that structural environment affects life and living itself. I mean, I know that. That's not even a question to me.
So every time
I just think very easy when we're thinking about public policy, think about the most marginalized population. Think about the most vulnerable first, that are going to be the most affected, and then you probably have a good place to start. If you think about the folks that are already the most comfortable and already enjoy the privilege of health, and you try to create systems that are convenient for that particular group, well, the system is going to be perfectly set up to get the results it continues to get.
So how do we as a medical profession inspire these changes? So for instance, a great question that's here said, every time there's a national trauma, we hear about mental health. Yet in between, it's very quiet. How do we actually address mental health, the issues that are out there, the addiction that's there? How do we bring this to the forefront so that it becomes something that's not just about these, flare-ups, if you will, the wildfires, but something that really we intrinsically address as a part of our healthcare system?
Yeah. I mean, I really appreciate that question. I think it's a really important one. Now in New York City, for example, there's been some effort to have hotlines available and make, online telehealth available for mental health, but that's actually not enough. I think one of the issues that we have is that our system is actually quite broken and it's been underfunded for too long. Wait lists to get mental health services has taken, they're really crazy long. And so it just is really difficult for people to get care. So I think that we have to have a different model of mental health care, and that model needs to be a public health oriented model where, mental health education is actually provided to a lot of people who are already the default counselors. If you think about yourselves as, primary care providers or teachers or nurses or, pastors and community leaders, all of these people are people that people already go to and probably already reveal things to, that can serve as frontline people to provide education about mental health, to raise awareness about mental health, to screen and refer. Because so much of what we do, mental health care, especially around depression and anxiety, can be done without specialty training. You do not need to be a clinical psychologist or a psychiatrist in order to treat some aspects of it. We've been doing task shifting quite a bit in low-income countries. I work in Vietnam, I work in Uganda, and I'm training the grandmas of a village on how to identify depression and provide behavior activation for depression. And we're getting rates of reduction that are like 80%. So it's possible, and it's been done consistently in other parts of the world. And we assume that we have better services here in the United States, but we actually don't. And I think we need to embrace a different model, and a model that really involves the community and activates all the different people who are already serving in that role, but without training. And I think if we provided that, I think a lot of things can transform, if more people had awareness about mental health and how it impacts health, how it impacts, your livelihood, how it impacts the way you live with your family, and, just everything. It impacts everything. So that's my little plug.
It's a good plug. We're getting toward the end of the hour, and actually over, but I don't really care, because I think what you guys are sharing is so important. I want to give each of you the opportunity kind of to express something here at the end and hopefully inspire people to follow in your footsteps, because you're all amazing people. You've done amazing things, and you've inspired certainly me. You've inspired our company to do things differently. But I also want to give you the chance to inspire others to follow in your footsteps, because and you'll see a slide at the end that I think that expresses what I feel that each of you are. But I'll leave that at the end. And Amy, do you want to take the ball and start it with giving us some words of inspiration for you and for what's passionate for you and how you can inspire others?
I really didn't want to start. I think my number one answer would be make health insurance universal. I think that's all I have.
Wow. You don't want to start big at all, do you?
The problems that we've talked about, if you can't access care, and oftentimes insurance is the ticket to get there, and there's a lot of arguments on that spectrum, but a lot of times insurance doesn't cover mental health. A lot of times those who need care can't access it simply because of health insurance. So I think that would take a big barrier away from many people and would be a good first start.
Wouldn't you love the discussion about healthcare to be about?
I know we're supposed to be doing the take-home message, but it's a huge first start. And just for the audience, in the United States, everybody doesn't have insurance. And when you look at outcomes, not having insurance, not having an identifiable source of primary care is one of the worst things that can happen. The years of life loss for the top 1% versus the bottom, it's like 10 years for men, 15 years for women, regardless of race, ethnicity. If you don't have insurance and a stable income and a place that's safe to live, if you're homeless or you're on the margins, you live very poorly in the richest country in the world. That's not my take home, though.
We'll put it down for you, but I think we could all raise their hand and say insurance for everyone makes a heck of a lot of sense. And at the end of the day, what's lost in that conversation is, candidly, it's much more cost effective. Forget all the economics. It's much more cost effective. All right, Keith, you're next. I'll give you the table next. Your take home.
My take home is that there's power in medicine, but the power is not our self-aggrandizement. It's not just getting good money so we can buy fancy cars. It's the power that people give their lives to us It's the power to help life create itself. And if we don't recognize that, then you should go do something else. Go work at a fast food restaurant or something.
All right, Ken, you ready?
Yeah, I think the first, and I love alliteration, so I apologize first off, but the acknowledgement. One, if the acknowledgement, if you're a person or you're in a place of privilege, you understand how you got there. Two, if you don't feel like you're in a place of privilege or you're marginalized, to understand that you have beauty, you have worth, and that you have people that will support you, so reach out. The acknowledgement that we are all one race. I was saying before when we had a prior conversation, we have a saying in my culture that's Mitakuye Wiwasan, which means we are all related. We all need to take care of each other. Finally, the next step would be, once you acknowledge, then activate. Please get engaged. Use that part of your brain to allow you to think through these barriers and these challenges that face us today. And then finally is to advocate for yourself and for others. And please keep trying to push the ball forward, I guess, is where we started out with. And that's where I'll end it. Thank you.
That's great. Victoria?
Yeah, I guess for me, I think one of the things that really struck me about everything that we've talked about is just how important all of these conversations are and how we need to institutionalize them. How do we raise awareness about this? We have to institutionalize it. We have to make it part of medical training. We have to make it part of, maybe earlier on in high school, in junior high, and, start helping people have these conversations. And then I think in medical school, I don't know that there's enough attention paid to mental health. And I think that needs to be introduced earlier on. Public health needs to be introduced earlier on so that everyone recognizes the role of these structural forces and how to have a more population health orientation so that we can help our entire society and not just treat a disease. So I think that for me, it's, seeing these bigger forces or these forces get institutionalized is really important.
That's great. Haval?
Zoom. I just want to support the message that Dr. Bernard and Dr. Fernand said. We need to take care of the underserved and the poor people in our community. I mean, there's a reason why all the faith and religion and prophet advocated for the poor and the underserved. Because if once you take care of them, you can take care of the entire community. And I think that's something we need to focus. And I hope that COVID unmasked that for us to bring that importance to this issue, because we know more people from certain groups and minority and underserved communities are dying from COVID and more likely to have worse outcome. So I hope we keep that in mind, that medicine is all about serving the underserved first, and then everyone else gets served after that because of those systems that works for them.
Inspiring words. And I want to leave everyone with this. This is an amazing panel of great people. And this is something that I feel passionately about. And you're often asked, what can one person do? And you can think about this in the way of a single drop of water. But when a single drop of water merges with other people, they can form a river. And that river, if that's dedicated and over a long enough period of time, can change the landscape forever. This is what we can do as people. This is what we can do as physicians. This is what we can do when we all actually follow the pathway that this great panel has done. So I want to thank this entire group for the commitment they've made to society, to the commitment they've made to the least of us, which raises the level for the most of us. And I hope that everyone out there actually follows in their lead, and we actually can change the way healthcare is delivered around the world, so that what we see in a pandemic, and there will be more pandemics in the future, that it impacts all of us equally, that we can share together in the way that healthy lives can be for all of us, because we're richer if we do so. So thank you, all of you panel, for being part of this. It's a special message you share. Thank you for being the people that you are and the contributions that you're making. And we look forward to continuing this dialogue with you in the future and bringing this to the forefront so that everyone can be as committed to this as passionately as you are. So thank you again.